want to welcome everybody to our endometriosis webinar tonight. My name is Dr. Kristin Riley. It's my pleasure to join you tonight and introduce you to our multidisciplinary team that cares for patients who have endometriosis and other conditions that can cause chronic pelvic pain. It's going to be a kind of a round-robin night where you get to meet lots of people who bring lots of expertise to your care. So just a quick background as we get started. Endometriosis is diagnosed by the presence of viable estrogen-sensitive endometrial-like glands and stroma outside of the uterus. It's a chronic inflammatory condition which can cause pain and fertility issues. It affects a large number of people, including 6 to 10% of reproductive age women. The average age of diagnosis is around 28 years old, and it can take 8 to 10 years to be diagnosed. It's been seen in premenarchal and postmenopausal women, as well as other populations too. And 38% of infertility patients have endometriosis. A majority of chronic pelvic pain patients have endometriosis, but there are a number of other pain conditions that we'll talk about tonight that can cause chronic pain as well. These are many symptoms that patients with endometriosis can present with. Painful periods is the most classic one, but some patients don't have painful periods. You can also have deep dyspareunia or pain with intercourse, dyschezia or pain with bowel movements, chronic abdominal and pelvic pain, adnexal masses, infertility, and other symptoms as well. We talk about lots of different medical management as well as surgical management for endometriosis. Tonight's not a specific talk about medical management for endometriosis, but these are some of the things that we use. Many of you have heard about things like birth control pills, progesterone, IUDs, Nexplanon device, things like Lupron, Orlissa, Myfembree, as well as lots of different pain medications. We use surgery to diagnose endometriosis. There's currently no non-invasive, reliable test for endometriosis. There isn't a blood test. There isn't a reliable imaging study that can diagnose endometriosis for sure. Laparoscopy continues to be the gold standard for diagnosis for this disease. We use excisional surgery to help improve pain symptoms for endometriosis and understand the amount of burden of disease patient has, and sometimes hysterectomy may be helpful, but it's not for everybody and it's not considered a cure. This is our team in the minimally invasive GYN surgery division. We care for patients with complex benign GYN conditions, and our practice has a focus on endometriosis and chronic pelvic pain. Many of you signed in tonight have seen some of these folks before. This is my picture. Dr. Arpit Dave and Dr. Linda Lee are the two other surgeons in our group. Faith Mong and Amy Santa Lucia are the nurse practitioners that you may have met in our group as well. Next, we're going to hear from Dr. Sarah Boyd from the Division of Urogynecology.
Hi, everyone, and thanks to Dr. Riley for including us in this webinar. So I want to just use the next few slides to introduce our specialty and what we contribute to the pain group. So a urogynecologist is predominantly a surgeon that specializes in pelvic floor disorders, and oftentimes this is including bowel and bladder issues and pelvic floor dysfunction. So in addition to myself, my partner Jamie Long is the other surgeon that is part of this group, and then our nurse practitioner Anna Posner sees patients. We see patients in office locations in Hershey, Camp Hill, and Reading predominantly. And the next slide will be looking at our most common disorders that we address. And so we commonly see patients for incontinence, which is involuntary loss of bowel or bladder contents, prolapse, which is a hernia in the vagina, emptying disorders, pain disorders involving the pelvis, bladder or urethra, or sexual dysfunction, which predominantly in the context of this group, we see quite often patients for female bladder pain syndrome, which was formerly known as interstitial cystitis. And we also evaluate patients for possible bladder endometriosis. And lastly, another common disorder is overactive bladder. So I just want to briefly introduce what female bladder pain syndrome is, because that is the most common thing that you will get referred to us to evaluate. So this is formerly known as interstitial cystitis, and the proper definition is an unpleasant sensation, either pain, pressure, discomfort, perceived to be related to your urinary bladder, associated with lower urinary tract symptoms for more than 6 weeks in the absence of any other identifiable causes. I like to think of this as a hypersensitivity disorder. So the lining of your bladder is very sensitive. And so when your urine hits the lining of the bladder, it makes you feel symptoms of urgency, going to the bathroom frequently, and pain or discomfort. Some people might just have a dull ache. When we see, for the next slide, sometimes it's often unclear what came first, if the bladder pain disorder is the thing that leads to other chronic pain disorders, or if chronic pain disorders lead to bladder pain disorder. We see that 44% of people that have a bladder pain symptom or syndrome has at least one additional chronic overlapping pain condition. And so that's why oftentimes patients get referred to our division, or vice versa. If they come to see us first, we'll often refer to our colleagues in this group, because more often than not, they'll have additional disorders. These are common comorbid conditions that I'm sure a lot of the specialists in this talk are going to touch on. So chronic musculoskeletal disorders, rheumatologic disorders, mental health disorders, general anxiety disorder, depression, irritable bowel syndrome, endometriosis, obviously, and pelvic muscle pain. I just wanted to end my portion of this talk with a list of common resources, which can be helpful when you're trying to tease out if this could potentially be you and if you may need an additional evaluation. So these 3 sources are vetted. So the American Urogynecologic Society has a great website called Voices for PFD that has a lot of patient-centered handouts and frequently asked questions. The IC Network and the IC Association are also very helpful tools and actually have a lot of patient forums. Thank you.
So much, Dr. Boyd. Next, we're going to move on to Dr. Jessica Dahmus, who's a gastroenterologist and sees a lot of our patients who have GI symptoms as well, that contributes to their pelvic pain.
Yeah. Hi, everyone. Thank you for having me tonight. Next slide, please. So my name is Jess Dahmus. I'm one of the attending physicians, part of the gastroenterology department, and we see patients with a variety of conditions, and that can include people who have endometriosis or pelvic pain that is unclear if it's related to their endometriosis or a secondary GI condition. Our current GI department has 18 attending physicians, 10 advanced practice providers, and 9 fellow physicians who are available for assessment, whether that be in clinic or in the endoscopy setting. So endometriosis can itself lead to a variety of GI symptoms, and whether that's due to endometrial implants invading into the bowel wall, hormonal changes leading to alterations in motility or hormonal signaling within the gut, changes in the gut microbiome, which is a burgeoning field of research for both endometriosis and gastroenterology, and then changes in gut motility. And then additionally, many patients who have endometriosis can have concomitant GI disorders, most commonly inflammatory bowel disease or other disorders of the brain-gut interaction. Next slide, please. Our team can help evaluate and treat those symptoms in a variety of different ways. We are open for clinical evaluation to help do the initial evaluation and workup for patient symptoms, and potentially provide medical therapy depending on whether we determine it's related to endometriosis or an alternative cause. Our team, we have an endoscopy suite present at the main hospital, as well as a private endoscopy suite across from the hospital that can supply colonoscopy. And then we have motility testing that can evaluate for pelvic floor dysfunction using a test called anorectal manometry. We have close ties with our nutritional service, and further research has been showing that there might be a tie-in with the relation in one's diet to both perception of GI symptoms as well as endometriosis symptoms. And then finally, we have acupuncture availabilities within our division as well. And I'll be happy to answer any questions towards the end of this session. Thank you.
Thank you so much, Dr. Dahmus. Next, we're going to hear from Dr. Kulaylat, who is one of the colorectal surgeons here at Penn State Health and helps us plan and manage complex endometriosis that can affect the bowel.
Hi, everybody. Thanks for having me. I'm Audrey Kulaylat, one of the colorectal surgeons. And thanks to Dr. Riley for inviting me. Nobody really wants to have to see a colorectal surgeon in general, I would say, but especially for endometriosis, when you have other things going on, this may not be something that you want to have to think about, but we are here to help and we are happy to talk anytime. As far as the prevalence of this goes, maybe about 8 to 12% of people who have deep infiltrating endometriosis will also have bowel involvement, and it's usually in the colon and the rectum as opposed to the small bowel. And it's important to note that no two cases are the same, so we have to look at each patient individually to figure out the best plan. Can do the next slide. We sort of already touched on these, but see, these are some of the symptoms that you may experience if you have bowel involvement. But just because you have the symptoms doesn't mean that there's endometriosis involved, and vice versa. The extent of disease doesn't always match the symptoms. But these are the questions that we might be asking ahead of time to see if you have a high likelihood or a higher likelihood of having bowel involvement. Next slide, please. So like Dr. Riley said, there's no official test that you can order ahead of time, no great imaging study to diagnose the endometriosis. But if we have a high suspicion for it, then these are a couple of the things that we may suggest getting ahead of time, which will help us kind of counsel you and predict what kind of surgery we may need to do. So sometimes that would involve an MRI or an ultrasound. And sometimes it involves coming to meet me in clinic, and I may discuss things like a rectal exam and kind of doing that in clinic to see if I feel anything involved down low, or even doing a mini colonoscopy in clinic or sending you for a full complete colonoscopy. In general, these don't find endometrial implants very often, but they do find them sometimes. But more importantly, it can help rule out other diagnoses that may be contributing to your symptoms. So that's a really helpful thing that we use colonoscopy for. And then if you do need a surgery and we have to remove part of your bowel, we like having a colonoscopy ahead of time to make sure that the colon is healthy enough to undergo a surgery. Next slide, please. So again, preparation is key because we don't always know what we can get into, but if we've at least told you all the possibilities ahead of time, you know, we don't like surprises and you don't like surprises. So that's the key. Next slide, please. So most of the time in surgery, you know, it's just a little bit of involvement, like the picture here on the left, and we can kind of shave it, if you will, off the wall of the bowel and just repair, you know, the bowel that's left behind, and then you don't lose any segment of bowel. However, sometimes we do actually have to take out a small segment of bowel that's been involved by the endometriosis, and then in general, we can reconnect that bowel so that you're still eating, you know, and drinking normally and then passing bowel movements normally. Next slide, please. If you have involvement down in your rectum, which is kind of right in your pelvis, it lays right behind the uterus and the vagina. So sometimes endometriosis likes to implant down there. Again, if it's just a little small area, we can often kind of shave it off and repair the rectum. But if we do have to do a large big resection of it, as in removing part of your rectum, it may be a much bigger surgery for you. Rarely, though, do we need to do something called a colostomy. I know a lot of people come to me assuming that that's what they're going to get, but that is quite rare. But I wanted to bring it up just so that you kind of know all the possibilities that we may be talking about if I see you in clinic. Next slide, please. So after surgery, if we just do a little excision or a shaving kind of the endometriosis, you're usually still able to go as an outpatient. If we do have to remove a segment of bowel and reconnect it, then you will be staying in the hospital for at least a couple days afterwards while we make sure that the bowels wake up okay. And then again, we talked about if it's a really low rectal resection, sometimes we do need to do a temporary colostomy, but this is super uncommon. It's just something that we always like to bring up ahead of time because, again, nobody likes surprises. And last slide, please. And if there's a high likelihood that you might have bowel involvement, just come meet us before surgery and we're happy to kind of assess you and talk through all the possibilities. Thank you.
So much. Next, we're going to hear from Dr. Brittany Crawford, who's a pelvic floor physical therapist, is going to talk about what to expect if you meet one of the pelvic floor physical therapists.
All right. Hi, everyone. As she mentioned, my name is Brittany Crawford. I'm one of the physical therapists on staff, and I've been working at Penn State for almost 2 years now. I work alongside my 2 other colleagues, too, Cody Long and Rachel Hoban, who is currently on maternity leave. So we see a lot of patients who have this condition at physical therapy all the time. And what we always say, especially the first thing, is no, we're not necessarily going to treat the endometriosis, but oftentimes there's a lot of musculoskeletal issues that coincide with endometriosis. So here are some symptoms that are listed on the slide that other people have already mentioned already, but some that we are able also to treat are things like constipation, lower abdomen pain, back and hip pain, some urinary symptoms that we're also able to kind of treat, in addition to, of course, pelvic floor muscle pain itself. And so that can definitely be a lot of the muscles that can just be overactive, that are kind of coinciding with a lot of pain with some of the symptoms on the slide. So inserting menstrual products, pap smear, pelvic exam, and kind of intercourse too. And again, all of this may be stemming from endometriosis, but a lot of these can also be some musculoskeletal symptoms that we can have effect on, and that we have seen a lot of patients benefit from kind of seeing us and kind of reducing a lot of these symptoms. Next slide, please. So here are some common findings that we often see with patients who are coming in to see us. So like I mentioned on the last slide, we often see a lot of pelvic floor muscle overactivity. And again, what that means is there's just a lot of increased tone or tension, or the muscles are in a contracted position for a long period of time. So I relate that to like my upper trap muscles. If my upper trap muscles are in this position all day long and they don't have a break, that is definitely going to cause some pain. It's going to give me neck pain, shoulder issues, headaches. And the same thing can happen with the pelvic floor muscles too. And so that can result in sometimes pelvic floor muscle overactivity can result in abdomen pain. It can result in kind of hip pain. It can result in, of course, kind of pelvic floor muscle pain itself, and kind of with anything intravaginally too. And of course, along with overactivity, there also just may be poor coordination of these muscles too, where it is difficult to contract them and relax them, which we should be able to do with any muscle group in our body. And some other things that we often see too is weak hip and abdomen muscles as well. And that can definitely contribute to some pelvic floor dysfunction too, because part of our pelvic floor are hip muscles. And so it will help out and try to compensate for our hips if our base of our pelvis is really weak. So my hips are weak, my abdomen's weak, pelvic floor is going to be even more overactive and can result again in all those symptoms we mentioned on the last slide. Some other things we commonly see too are poor breathing patterns. So we are big proponents of diaphragmatic breathing because it allows for natural relaxation and contraction of the muscles. Whereas a lot of people who are just predominantly like chest breathing, we don't get that natural ebb and flow of the pelvic floor muscles that kind of will allow it to relax and kind of get out of that overactivity. And then last but not least, we can also see some poor flexibility of the low back and hips too. And you can imagine if my base is really, really stiff and kind of tight, my pelvic floor will probably also be very kind of overactive and in that contracted position as well. Okay, and last but not least, some common treatments that we usually do in pelvic floor PT. So definitely the first day when you come in to see us, number one, we're going to do a really kind of long history. We're going to ask you a bunch of questions. We're going to get to know one another. But also the really big thing we do on day one is a lot of education, because most people when they come to see me have no idea what the pelvic floor is, okay, and what the muscles groups are. So we do a lot of education about the muscles, kind of where it is, how it functions, how it relates to all your symptoms. And then also typically some good like behavioral and lifestyle changes that can kind of implement, that you can implement from the day one, okay? In addition to all of those, some other kind of treatments that we also do kind of relate to the muscle groups is definitely pelvic floor relaxation or stretching, right? So if my upper traps are in this position, I really need to kind of stretch, let them relax, let it calm down. And then oftentimes we get a lot of decrease in that pain. And then we also can definitely add some low back and hip stretching in. So we are improving the flexibility, allow pelvic floor and just the pelvis in general just to move better. And like I'd mentioned previously too, if my ab and hip muscles are weak, let's strengthen them. So we have a really good base of support. So the pelvic floor can do its job even better than it was before. And then last but not least, we are also qualified to do some soft tissue kind of mobilization and massage in different muscle areas and groups that are affected. So again, we can do some abdominal massage, we can do some hip and kind of glute massage, and then also we can do some pelvic floor massage that can be externally or internally depending on the patient, and obviously consenting too. And so again, those are just some typical treatments that we see. But again, there's often a lot of muscle issues with endometriosis that we are able to treat and just have some tools in your tool belt to try to reduce the pain on your own.
So much, Dr. Crawford. Next, we're going to hear from Dr. Sadie Smith, who is a anesthesiologist and interventional pain medicine specialist, and sees a lot of our patients who have chronic pelvic pain and many of the overlapping conditions that we've talked about.
Thank you very much, Dr. Riley. Again, my name is Sadie Smith. I'm one of the interventional chronic pain specialists. We have 9 total chronic pain specialists in our group, but I see more pelvic pain patients than I think any of the other chronic pain specialists. So I just wanted to tell you briefly, but what is a chronic pain physician? So this is generally a physician that has completed a 4-year residency in either anesthesiology or physical medicine rehabilitation, in addition to a 1-year fellowship in interventional chronic pain. However, some interventional chronic pain physicians did internal medicine, emergency medicine, or psychiatry as a residency instead of anesthesia or physical medicine rehabilitation. A chronic pain medicine specialist treats all forms of chronic pain, that's including but not limited to spine-related pain, myofascial pain, neuropathic pain, and pelvic pain. So this is what I wanted to talk to you guys about today. Next slide. So what can I do for chronic pelvic pain as a chronic pain management physician? So when I see you in clinic, I'm going to do a very thorough evaluation on our first visit to rule out other musculoskeletal causes of pelvic pain. Oftentimes when I see patients with pelvic pain from endometriosis or other pelvic pain conditions, they often or sometimes will have other musculoskeletal conditions that will be masked by their pelvic pain diagnosis. I've seen patients who have hip arthritis that didn't know it when they came in with chronic groin pain. I've seen patients with lumbar facet arthritis, with SI joint arthritis. So I try to evaluate and rule those things out to make sure that that isn't also contributing to your pain. And there's things that I can do physical exam, I can get x-rays. And so that's kind of how I evaluate and rule those things out. Once I try to classify the pelvic pain, is it coming from the abdominal wall? Is it coming from the organs inside the abdomen, which is known as visceral pain? Or is there a nerve problem causing what we call neuropathic pain? And based on how your pain is classified, I'll offer different interventional treatments that may be appropriate. And this can include ultrasound guided or certain x-ray guided injections that can provide anywhere from 2 to 4 months of pain reduction. Now, I understand that these treatments aren't permanent treatments, but they can provide some relief for patients that are suffering from pelvic pain. Next slide. In some patients, in some cases, I can offer nerve stimulation implants as treatment for pain. In addition to the interventional treatments that I offer, I can also provide medication management and recommendations depending on what kind of pain you have and your other medical conditions that you have. I also offer referrals to complementary specialists that you're going to meet tonight. But I try to work in a very multidisciplinary fashion. Most of the time I get referrals from Dr. Riley and the MIGS group. Occasionally I'll get referrals from outside of Penn State. But if you haven't seen somebody from our MIGS group, I will be referring you to them as well for an evaluation. I see patients in both Hershey and in Lancaster. Currently, I have more Lancaster openings than I do in Hershey. So if you're wanting a referral to me, just know that my Lancaster location does have more openings.
Well, thank you so much for that information, Dr. Smith. Next, we're going to change gears a little bit, and we're going to talk about endometriosis, fertility, and fertility preservation. You're going to hear from Dr. Samantha Butts, who is the chief of our division of reproductive endocrinology and infertility. And she really brings the fertility lens to our patients' care and helps them manage their pain management goals and their fertility goals as well.
Thanks, Dr. Riley. Can you hear me?
We can.
Okay, great. I just want to take an opportunity to thank Dr. Riley and in her efforts to organize this, webinar and bring all of these amazing experts together. So as she said, we work in collaboration a lot. Dr. Riley, her team, and myself, and members of my team. I was actually on the phone with Dr. Smith earlier today, reaching out for some consultative help. So I think one of the things that hopefully you leave this meeting with is the impression that this is a team, not just in name, but really in deed. And I think it's one of the major strengths, and kudos to Dr. Riley for building it. I will keep my comments brief, but I do want to lead with one very important fact, which is, we know that endometriosis is prevalent. And one of the things that we see in association with endometriosis, sometimes upwards of 30% of the time, is that patients have difficulty achieving pregnancy. The why is often, something that our patients are asking us, and we are trying to understand. Some of this is theoretical, and some of this has been well researched. As has been pointed out before, and as probably a number of people on this webinar already understand, is that endometriosis is a chronic inflammatory condition. And when that's happening, we are concerned that there could be some impact on the function of the ovaries or the fallopian tubes, sometimes in ways that are not even visible, sort of on just evaluation of these organs, but maybe on the cellular and molecular level. It makes complete logical sense that when endometriosis is more advanced, stage 3, stage 4, where there are larger implants of endometriosis, deep infiltrating endometriosis, that this can distort the normal anatomy of the female reproductive tract, such that the fallopian tubes are involved, scarred, and blocked in some cases. We believe that when there are significant implants of endometriosis in the ovaries, there can be production of oxidative stress, which could impact the function of ovaries in terms of how they produce hormones, the quality of eggs that are adjacent to this oxidative stress, and the reserve of eggs that are available to an individual person trying to achieve pregnancy with or without the assistance of a fertility specialist. I'll take the next slide. I want to also point out this very important slide, which is now almost a year and a half old. The American Society for Reproductive Medicine, which is the major professional society for fertility specialists in this country, had the presence of mind to release a committee opinion updating how we define infertility. Why is this important? Well, it's important because it validates what our patients experience. It's important because it aims to get everybody on the same page about what barriers to fertility are. And not for nothing, it's important because it sends a message to the payers, the insurance companies who are making the decision about whether I get to take care of you and whether they are willing to pay for it. So we want to have incredibly both valid and inclusive definitions of what infertility is. I know this is kind of small type, but the gist of what this definition is getting at is, your ability to achieve a pregnancy, if there are any barriers to that based on your medical history, endometriosis, reproductive history, endometriosis affected, and other very, very important factors in your life, these should be considered and thought of when determining if you should have a conversation with a specialist like me. Very, very fortunate to work where I do, because there is an awareness and thankfully a growing awareness that, our subspecialty exists, that people can access what we do, either when they have been struggling to get pregnant or when they have an awareness that it might be difficult. And from my perspective, I'm happy to talk to any patient anytime, and I don't want you to wait to try for a number of years. Come see me before you even start trying. Let's have a conversation prior to pregnancy attempts so we can be intentional, strategic, multidisciplinary about the path you take moving forward, and we are using your time wisely. I'll take the next slide. This is a website that just sort of introduces you a little bit to our practice. As other members of this webinar pointed out, we are in more than one location. We primarily see patients in Hershey on Hope Drive, but we also have a satellite in York in Leader Heights. We have 3 physicians, 2 outstanding nurse practitioners. One of our nurse practitioners is actually located in Camp Hill and sees patients there as well. So we're really in 3 locations. And this is what you see if you Google reproductive endocrinology and infertility at Hershey Medical Center. Really finishing up my comments, this is a list, not completely exhaustive, but fairly representative of the type of services we offer in the reproductive endocrine and infertility division at Penn State Hershey Medical Center. We are full scope REI infertility, which means we offer the full scope of, IVF treatments, non-IVF treatments like ovulation induction with oral medications, injectable medications, intrauterine insemination. It really does depend on what the needs of the patient is. And that's why both of these columns lead with consultation, because first and foremost, I need to understand what you need and what is best for you in your efforts. I put on the right-hand side here fertility preservation. We offer egg freezing to patients with and without endometriosis. But one of the things I tell my patients with endometriosis who have not started trying is to become pregnant is that endometriosis is a chronic, often progressive disease. And it's never, as I said before, too soon to have a conversation about what your fertility goals may be in the future and how we can help you express your desire to build a family when there may be challenges that you haven't even conceptualized yet. I'll take the next slide if I have one. That might be my last slide. And thank you all, and look forward to questions and dialogue later. Thank you.
So much, Dr. Butts. Next, we're going to hear from Dr. Titika Baweja, who is the medical director of the Reproductive and Behavioral Health Program. She's a psychiatrist who has a focus on women's health, and we're so grateful for her leadership in this space.
Thank you so much. I would like to say thank you all for joining tonight. And I share the same sentiments of all the panelists that Dr. Riley, thank you so much, you and your team, for organizing such a educational, much needed session. Thanks to the marketing team. So as Dr. Riley already introduced me as Medical Director of the Reproductive and Behavioral Health Program. I'm here to kind of introduce briefly our program. I won't take many slides, but we'll just take a couple of slides to explain what our program is. So this actually an easy way to explain this is a one-stop shop. So we actually, through our program, provide the services which you heard quite a bit of challenges the patients with endometriosis go through. So we are a team of reproductive psychiatrists, 3 of us, psychologists who will be actually presenting soon and sharing about her services. We collaborate with various other team members you saw here, pain management team, our chronic pelvic pain mixed team, as well as substance use providers and OBGYN providers. Next slide, please. So what do we do actually in this one-stop shop to say basically is we start from the time of reproductive phases, menarche to menopause is where we end. You may have heard people going through a painful menstrual cycle, and that's finally the starting symptom for many patients to finally end up going to the endometriosis diagnosis years later, basically. So we start by treating the PMDD. Many patients who get diagnosed with endometriosis down the road, you heard about infertility. That does not come without challenges involving mental health. So we provide services for them. Patients who are fortunate to be pregnant, we do provide care to pregnant and postpartum individuals. It is seen that trauma is a big connecting link with physical symptoms, mental health symptoms, substance use. So we are fortunate to have providers to provide trauma assessment, and it does not have to be only endometriosis patients. Of course, we provide care to patients who do not have endometriosis. Patients with trauma, we have psychological services to provide them trauma-informed care. We have psychiatrists to provide them medication management. We provide services mostly at Hershey location at Hope Drive, but we also have a psychiatrist at PPI in Harrisburg location. We collaborate with our maternal substance use disorder program, where we treat patients struggling with drug and alcohol problems, with most focused on opioid use disorder during pregnancy and postpartum periods. And I will say now the final collaboration to kind of stress for today's webinar is our chronic pelvic pain collaboration. The easy way to explain this collaboration is a mutual referral, which is a warm handoff. I would say a simple way to explain is that we know our patient, and actually I will be the last person to get, I believe, because you have gone through, the individuals with endometriosis have gone through most of the providers you already kind of heard before me, that because of all the physical limitations. So when you are referred to me, is you have major struggles with mental health. And that's why I'm not going with telling you all the signs and symptoms of depression, anxiety. I'm sure my esteemed colleagues may have already caught all those symptoms to share. Yes, we are not there yet in terms of endometriosis and mental health relationship, but we know that endometriosis can cause mental health challenges. Depression and anxiety disorders are commonly associated. Eating disorders can also be associated as per some studies, and that is why we are here to provide medication management if you need. We have psychological treatment. That is what I will defer to Dr. Coleman for her detailed services. But I want to say one line at the end, that through our reproductive behavioral health program, we are trying to provide multidisciplinary approach, holistic approach, psychosocial interventions, which is what we know as per research has been helpful to provide full, holistic, comprehensive treatment, physical and mental health for patients with endometriosis. Thank you for your time, and feel free to put any questions for me or us in a chat regarding our program. I'll pass it on to Dr. Coleman.
Thank you, Dr. Baweja. Next, you're going to hear from Dr. Christa Coleman, as Dr. Baweja just said.
So good evening, everyone. And thank you both, Dr. Riley and Dr. Baweja, for that introduction. So I'm a psychologist, and the area of practice that I utilize for psychological interventions is with people who have pain and or trauma. So I believe, as far as I'm aware, that I'm the only pain psychologist at Penn State Health at this time. Hopefully we change that as well. I do work in 2 different clinical locations currently. So there's one where I see folks who have a variety of different chronic pain conditions. And then the other one is in the Women's Health Clinic. And that's where I work with folks who have pain, but I also work with people who've been diagnosed with PTSD and who are seen through the Reproductive and Behavioral Health Program, as you just heard. So one might say that I help people living with physical and psychological pain. I am trained in all of these listed psychological therapies, and I use a variety of different treatment options when working with patients. So it's not the same thing with every individual who I see. I do think it's important to just sort of reiterate what Dr. Baweja was talking about, and mention that there are higher rates of mental health disorders with endometriosis, and we're still trying to understand all of that and why that is. But we know that they're there, so we want to treat them, right? And so when I start working with someone, we discuss the treatments, the very onset of treatment. And these treatment options are really grounded in the research on pain and on trauma. These therapies have demonstrated positive impacts on symptoms and quality of life for those who are living with either PTSD or chronic pain or both. And I realize often people are sort of unsure what treatment might look like. So kind of wanted to kind of give you a few examples. So cognitive behavioral therapy, oftentimes referred to as CBT, it's a standardized treatment for pain, but also for PTSD. Some patients who come to see me are really looking to understand what's going on in their bodies, to learn some ways to better manage their symptoms, improve their quality of life. They might lead very busy lifestyles. They want to gain as much information as possible, as quickly as possible. And, these individuals are really great candidates for my pain group. So it's a telehealth group that's focused on education and skills to really address the thoughts and emotions, to help them learn ways to kind of pace their activities, to improve their sleep, stress management, and even to help with communicating their needs with other people. But it's not a support group. It's for 1-hour telehealth sessions, so very manageable. And, patients might also come to see me for PTSD, as I said. So one treatment option is eye movement desensitization and reprocessing, which you see on the slide here too. That is an individual therapy. It's also personalized to the individual, and it might be anywhere from 6 to 12 treatment visits on average, just to reach the treatment goals of reducing or eliminating PTSD symptoms. The great thing about all these therapies listed is that they are skills that you have then, and you can continue to use them in the future to help yourself. Next slide. And I'm also passionate about moving forward research on endometriosis. And I do have a current study that is really seated in the research on prehabilitation. So if you're not familiar with that term, and many are not, it's a growing understanding about the importance of making healthy lifestyle changes in preparation for surgery. So to pre-rehabilitate in order to improve post-op outcomes. So my research in this current study that I have is really interested in how mindfulness practice can improve people's outcomes from surgery for endometriosis. And so if you are interested in this, you can always talk with your MIGS doctor, or if you have one of your other doctors that will be doing surgery with you, you can certainly talk with them about other research options. And I think we're going to hear a little bit more about that today too. Thank you.
Great. Thank you so much, Dr. Coleman. Next, we're going to hear from Dr. Lacy Alexander, who is a professor of kinesiology and has a research interest in endometriosis and cardiovascular health. I think sometimes we get so focused on sort of the acute parts of and challenges of this disease, and it's good to look at some of the bigger picture questions as well. Thank you so much for being here, Dr. Alexander.
Great. Thank you, Dr. Riley, for that introduction. And I really want to thank all of you for joining today and all of the panelists for being here. I've certainly learned a lot. So my interest is actually in cardiovascular disease. And I have a special interest in learning why women with endometriosis in particular have about a 50% greater prevalence of cardiovascular disease earlier in life than women without endometriosis. So, what are some of the reasons why there's greater cardiovascular disease risk in women in general as opposed to men? Well, so the problem is that most clinical research to date has been done in men. And there's certainly public misconceptions about the impact and the prevalence of cardiovascular disease and even how the research has guided our guidelines. So what's the solution for this? Well, one of the solutions is to increase recruitment in clinical trials and really deliver better education and have more research on what is the impact of hormonal influence on cardiovascular disease risk. And I think importantly, what are some of the unique women-specific risk factors for cardiovascular disease, including endometriosis? Next slide, please. So we're all aware, and I think it's been nicely stated today by the other panelists, that inflammation is really at the center of many of the comorbidities that are associated with endometriosis. So I like this slide, this cartoon image of how inflammation not only impacts the reproductive system, but also impacts everything from the brain, and even how our metabolic system and those fat cells and our liver change our metabolism with endometriosis. We also know that inflammation, and next animation, please, inflammation is at the center of long-term cardiovascular complications in women with endometriosis. And so my research lab has spent some time, and we actually just recently published a paper on how inflammation impacts cardiovascular function. So next slide, please. So what we're interested in is how the blood vessels, and in particular, the very small vessels, as well as the larger vessels in our bodies, respond to different stimuli. And when we do different things in the laboratory, we image some things, or the brachial artery or some of the larger arteries, utilizing ultrasound. We also use different approaches where we examine the microvessels in the skin as a window into what is occurring in that microcirculation. The current studies we have going on in the lab are all funded by the National Institute of Health, and they involve everything from looking at different study medications to looking at how exercise may impact, say, blood pressure responses, to just something as simple as hand grip exercise. Our study visits are occurring both at Penn State Hershey Medical Center within the Clinical Research Center, as well as at University Park, so on main campus at the Knoll Laboratory. So typically our study visits, one study may have up to 3 visits and may just be as simple as a 1-hour screening visit, and the actual experimental visits are up to about 4 hours in length. And we do compensate you for your time as well as for any travel expenses that may occur. And I also want to say that, throughout my experiences working with women with endometriosis, you all are all a very altruistic group of individuals. You've gone through a lot, and I think everybody wants to know what can I do to help other people? And so, I think that volunteering for research is a really great way to help others that are going through this and to potentially help in terms of finding treatment strategies and other things that we can do to help mitigate long-term risk, as well as just better understand this disease process in general. I think you've heard all of the panelists say tonight, we don't know a lot about this disease and we're learning more every day. So I want to just encourage you to be involved in research, and the fact that we really appreciate your time and what you go through, and hopefully we can all learn from one another. So here's some information about what we're currently looking for research participants, as well as a QR code that you can screenshot to take you to our page to fill out some information, and our research nurse can get back to you.
Thank you so much, Dr. Alexander. And again, I want to thank all of our panelists tonight, and I want to thank all of you for joining us as well tonight. Again, endometriosis is just one component of chronic pelvic pain. It's important to consider all comorbidities and a holistic approach to get patients to long-term pain management. As a lot of people, as you all know, we don't have a cure for endometriosis, but we think we can manage this disease well when we take this holistic approach and take a multidisciplinary approach by leveraging all of the skills that we all have. And we really do believe that a multidisciplinary approach to care will lead to patient-centered long-term management. Our team is pretty incredible. I feel lucky to work with everybody on the team. The people that you met tonight are just kind of a small group of us, and our team continues to grow all of the time. I think this makes us pretty unique in how we communicate. It's not just through referrals and emails. We meet regularly to discuss patient care together and to learn from each other. And I think that's important to endometriosis care, being willing to kind of, always find ways to learn and grow in this field.